And today is no different. We have a couple of case presentations which show the complexities and the difficulties we deal with. So there's another D in there, difficulties. Great honor to have our colleagues from Tacoma here. They're wonderful colleagues, Drs. Martin Covey and Brittany and team. They're wonderful colleagues with great insights and many challenging cases in the South Sound area. Thank you for taking the trip up the road. We have a fantastic visiting professor today, Dr. Alan Daniels. Alan, are you live?
I'm here. Thank you guys, appreciate it.
I can hear a first vocal clip. There you are. Alan, I was wondering whether you know this guy. Dr. Hart can come up here. So Dr. Hart's one of our esteemed partners, and I just thought you'd say hi.
Well, it's actually a delight to have the opportunity to introduce Alan. Those of us that participate in educating surgeons and should all have at least one Alan Daniels in our, I don't know, portfolio or history. It was my great pleasure to meet Alan when he was a medical student down at OHSU. He somehow found me. I don't know exactly how that worked out, but he turned out to be just an incredibly thoughtful, incredibly energetic and dedicated researcher who knew at that point that he wanted to go into orthopedic surgery and seemingly knew that he wanted to go into orthopedic spine surgery. And so we've continued our friendship and working relationship since then. I don't know, I would like to claim credit for some of the things that Alan but I really don't think that's probably fair. I think I should probably more thank him for furthering my career in various ways. And with that, I'll turn the microphone over to Alan and look forward to his discussion of spinal alignment. And he's going to emphasize a paper that'll be coming out in JBJS sometime in the next coming months about height restoration that really came out of an idea of one of our fellows here, Zach Tatterin, but the legwork and the heavy lifting, as often occurred with projects that I worked with Alan on, was done by Alan and his team. So take it over.
Thanks, Bob.
We're not going for the talk yet. We're going for case presentations, but thank you, Bob.
Thank you, Bob.
And we'll repeat the accolades a little bit later again. But thank you, Alan, for joining us here. And before we get started with our cases, maybe I'll ask Gautam Rao to come up first. I wanted to acknowledge our SSF staff. We just had our 14th annual Spine Residents and Fellows course here, and it was a complete sellout. This was a packed house here, and over 2 days to roving accolades, and it was really very cool to see. Alan, I hope we'll have you here in the future. If it's okay with you, we'll have 3 cases for you which show some of the highlights and challenges that we face in spinal deformity surgeries. So first off, Gautam Rao from the University of South Florida. Gautam.
Thank you, Dr. Chapman. Let's see if I have this up here. Great. Okay. Everyone see the presentation? Just a presentation on a recent case that we did a couple of weeks ago at our institution here at Swedish. No disclosures relevant. This is a 54-year-old male. He has a history of AVR, currently on anticoagulation from a congenital heart issue. Previous history of an L2-3 laminectomy for a herniated disc that was causing radiculopathy. Has been seen in our clinic for multiple years, really with overgeneralized back pain. Past year or two is kind of worsening in terms of his overall back pain, quality of life, and deformity that he says he has. This is a X-ray, lumbar spine in 2019 when he first started to see us. Slight coronal deformity, but nothing terrible. Just again, overgeneralized back pain. This is prior to his herniated disc that he had the laminectomy for. Everything was doing well, and then he sees us again early this year with this radiograph. He now has a more significant levoscoliosis or adductor scoliosis with significant foraminal stenosis and overall worsening coronal deformity. Are his scoliosis films from that same year, 2023. You can see his sternal wires present and coronal deformity there. His sagittal plane looks okay with a good SVA on him. Here's his lumbar spine CT scan showing the degenerative nature of his osteophytes and his discs. You can see his major lumbar curve with the small minor thoracic curve, and kind of stops around T6. Kind of everything straightens out then. We opted to do a minimally invasive approach on him. We did a 2-level XLIF. We were trying to do a little bit more, but given the proximity of his ribs to his pelvis on the left side, we were somewhat limited and only able to do 2 levels. Even when we broke the table, it was able to give us a good view on those 2 levels, which fortunately were the more scoliotic curves. Afterwards, we did a minimally invasive T10 to pelvis using multiple incisions, but using navigation as well to get him decent alignment in the coronal plane. These are his post or pre-op images, again, just for comparison. And then this is his post-operative image, shows a good coronal correction. Cobb angle went from 36 to around 3. So we had decent alignment there. The sagittal looked well as well. I didn't put that up there though. All the screws were good. We used the navigation, used the X lifts in order to get a better end plate proximity and deformity correction, which you can kind of see here. This is just a plain radiograph, abdominal X-ray, not a true lumbar, but you can still see compared to previous, it's improved quite substantially. Post-operative course, after the XLIF, there are no issues. Fortunately, no femoral nerve palsy, no quadricep weakness, no numbness anywhere. Interestingly, even the day of the T10 to pelvis, which was kind of a staged procedure, he was fine in the morning, then afterwards developed some quadricep weakness on the left side that has been improving even in the most recent clinic evaluation. In terms of future possible interbody L5S1, we'll see how he does and see if there's extra stress on that joint or not. But otherwise, that's kind of an interesting case that we're able to get a good deformity correction using minimally invasive approach in order to correct some of his coronal deformity. Any questions?
So go back to the timeline images that you had juxtaposed, and we don't have sagittal images? Nice.
No, not for the scoliosis films.
That's a shame. So obviously one of the big questions is this MIS craze, Alan, but if you go into this, you are a member of the ISSG. And again, one of the big questions is prognostication of scoliosis and spinal deformities. And I'm from an area where we were taught 1 degree in the lumbar spine per year. Where are we in your data analytics in terms of trying to predict the future in a 2019 patient who presents in 2023 with this kind of an image to kind of see how much this will progress and how symptomatic this will be?
I don't think we've progressed very far from the 1 degree a year data yet. I think that that's also what I was taught, and I still tell patients that to this day. And I think you bring up an excellent point that we really need a better idea of how to prognosticate, because when I see that image of 2019, I did not predict it would look like it did in 2023. I thought, yeah, the lateral aesthesis might get a little worse and it might have progressed 5 to 10 degrees, but this patient really went over a cliff and got catastrophically worse. Do you mind showing us the lateral x-ray? I also agree with Dr. Chapman here that I worry a little bit when you say the sagittal looks good. I think overall the SVA is clearly normal, but I think having a slightly deeper dive into the sagittal alignment is important. Not to say that it definitely needs correction, but at least needs to be paid attention to. You know, the pelvic tilt is a bit elevated here, so I'm just not quite sure with these films what the lumbar pelvic alignment really is.
Let me ask Dr. Hart. Dr. Hart, anything that would have prognosticated that this guy is going to just literally just derange over a relatively short time period? Sternal wires, lack of buttock strength, anything?
Yeah, I don't know how to predict something like this. I think, natural history of scoliosis continues to be something that we know a bit about, but we don't know everything about. I don't know with some of the emerging AI whether we'll be able to pick out features in this gentleman's history that suggest he's at risk for progression. I'm not sure it matters. I mean, at the end of the day, if he's not struggling with pain in that first x-ray, none of us are probably going to operate. I think, on the other hand, if that first x-ray, if he's miserable and he's tried every other conservative measure, many of us would, and I think I would probably sign him up for surgery if he was at a point of wanting that based on his symptomatology more than his curve. So why this one went so badly so quickly, I'd just be scratching my head. And I would underline what Alan said regarding the sagittal plane here. I think SVA is not the entire story, and this gentleman has what we would consider, I think, compensated sagittal malalignment. He is not well aligned in the sagittal plane, and he's extending through his thoracic spine, and he's retroverting his pelvis a bit to compensate. I don't think he's quite to the point of crouching. He's not got bent knees, but he does not have a suitable sagittal alignment.
And Gautam, go back to that juxtaposition X-ray, which I always, whenever I see deformity patients, I go back to the first spine images in our PAC system and try to compare over time and learn from it. So did he have neurologic symptoms? How did he do in 2019? Was he still pretty happy? And
Yeah, he was mainly a happy guy, just had back pain. That was his primary concern. And then really in 2000, and then we had the laminectomy for the herniated disc, which was due to radiculopathy. And then in 2023, he was essentially saying, when I try, he's an avid runner, but he says that his ribs are hitting his hips when he's walking, running, things like that. So he had a worsening deformity, and that's kind of what prompted evaluation.
so let me ask our dear colleagues from Tacoma, Dr. Martin, Dr. Covey, in 2019, hypothetically, taking a time travel back, a limited fusion for this segmental collapse, L23, L34, would that have been a consideration, especially in reflection of the fact that in outpatient surgery centers now, these limited mid-lumbar fusions are very popular because they can be done kind of as outpatients. So any role for a limited fusion back then to avert the big surgery?
I wouldn't do anything surgically with him if he wasn't symptomatic, not just for the radiographic findings alone. I don't think that that's indicated just for the deformity.
Dr. Covey agrees?
Yeah. Of course, this is not the rule that somebody progresses. It just happens in just a relative minority of the people. And I don't know why people can't decompensate, but if he was running in 2019, I don't think a 3-level or 2-level fusion would have been appropriate.
We have the great benefit of having some co-panelists here from across the seas. So Dr. Tarush Rustagi, can you unmask your video and microphone? And Dr. Tariq Sohail from Lahore. Tarush, are you live? I see you. I'm just wondering whether we are too restrictive in the US. If not, we'll go ahead. So the other big question, Alan, is that of MIS. And MIS is, again, obviously a great selling point for patients, less trauma, percutaneous fixation, fast hospital stay. If you go back to or go forward now to the post-op images, the hardware looks very nicely placed. There's an undeniable deformity improvement. Yeah, this is a good one. But the only place that I can identify a potential for fusion are the two locations for the large metallic devices that were inserted through the far lateral approach. There's no S1 screw in there. We don't have a sagittal image. So is this a short-term hype? And I don't know how many access points were made, 10, 12, 14 incisions. Is that less traumatic, and is the long-term healing effect known at this point in time, Alan?
Yeah, I'm going to address two things. Bob also brought up the prognostic factor of well, doesn't matter if you know if he's going to progress, but as people age with bone density, if you told this gentleman he had a very high likelihood of progressing, something like a minimally invasive L2 to 5 fusion might have been a great option for him, assuming you get him diffused, may have prevented this. So I think there's a real role for MIS. And actually the data, I'll say that there's a large group of surgeons who do MIS deformity that have tried to show that their data can provide good long-term 2 to 5 year outcome. However, to do that, you have to really achieve a fusion. I worry about the lumbosacral junction. You know, your last slide said possible L5S1 fusion. I think if I had heard that there was a definite plan to do an L5S1 ALIF, I'd be more confident that we've built a solid, fused, stable, well-aligned foundation. And I'd be a little more optimistic. I'm concerned that this patient will have either screw loosening or rod breakage at some point in time.
And that comes to the multi-rod construct, I'm sure, or you'll probably mention that later, and we'll see some cases, I think in the next 1 or 2 cases where this will become a point. Multi-rod fixation, a lot of deformity surgeons have resorted to that now. Is that a possibility that you've seen on the East Coast with MIS surgery?
Not with MIS. You know, we do, for us at Brown, multi-rod construct is essentially the standard of care for any, you know, thoracic to pelvic fusion, especially with an osteotomy or aggressive fascitectomies. But I have not seen it in MIS. And I remain concerned that even a multi-rod construct will break their rods eventually if there's not a fusion or at least a functional fusion. You know, you don't have to see a huge wall of bone from BMP to be a true fusion. But if the facets are fused and the patient has a relatively stiff spine, they may survive over time. But this individual, if they have a lot of disc mobility, something will give eventually.
So, Gautam, give us a little performance assessment. So, did the patient require any blood transfusions? How long was the patient in the hospital for? Did the patient go home? What do you know so far about him?
So the patient, we had first stage of the operation was a Monday elective, and then he obviously stayed overnight. Sorry, no, it was Tuesday for the first stage, and then Wednesday for the second stage. Didn't require any blood transfusions. The case was probably first case maybe hour and a half to get those 2 inner bodies in. Second stage, probably 4 or 5 hours in terms of the screws and rods. Yeah, the rods actually went in pretty quickly. Fortunately, that's kind of something that can be an issue with these long constructs in order to get all the towers to line up, but we made sure that we had all of our incisions lined up to help with that. He probably would have gone home probably by Friday if he didn't have the postoperative weakness, which led him to stay and get some rehab through PT inpatient for a couple of days until Sunday, where he essentially said, "Hey, I can do all this stuff at my house. I'll feel more comfortable." So we allowed him to go, and again, he's a pretty responsible guy. So he overall hospital stay 5 days. In the hospital, probably less if he didn't have that weakness postoperatively.
So Rod, Dr. Skurin joined us. Can we, you probably have to use, maybe this microphone will work. Yeah. So MIS versus open procedures, share your thoughts. Why not open? Obviously, it's nice to have stayed in the hospital for just 5 or 6 days. Patient has some thigh weakness now. Open, closed, and he'll have to come back for an ALIF or even a 2-level anterior procedure. So the surgery accounting is not over yet if we take a more global perspective.
I mean, I think those are valid questions. For me, the main issue is, PJK is a real thing. And, when I've done MIS deformity, my PJK rate goes down. Now, you do have to deal with pseudoarthrosis and other things, but I just, again, on a patient like this, I think there's nothing wrong with doing quad rods, doing a big open surgery, but I think an MIS procedure, there's definitely some advantages. So.
Yeah. So all good points. So any final thoughts there? Are you doing MIS? I mean, you're in a very competitive environment in Rhode Island, it's Boston, Eastern Seaboard. Is that becoming kind of an expectation by the patient clientele, or is this something that you can just do what's right in your opinion and proceed?
Oh yeah, I don't do any MIS deformity correction, and because in my hands, I believe the most tried and true method for optimizing alignment, achieving fusion for me is open. Amazingly, the patients here in Rhode Island, Boston really are not requesting MIS at this point in time. I have a current fellow who wants to go work in Long Island, and he's told me that down there, you know, if you don't do MIS, patients aren't going to come to you. But here in the Northeast, we're still using open techniques primarily, and the patients haven't run away yet.
Yeah, so interesting perspective from our long-term follower, Dr. Farzan Farakbash. He says, again, reducing blood loss is a really big deal, especially in older patients, so less invasive procedures are beneficial. And again, frailty, those are clear factors. So the blood loss reduction was significant. The amount of incisions in the back, I saw the patient in follow-up was substantial. I think there were 10, 12 cuts or so, but the patient actually looked remarkably good. I have to admit, I'm an open surgeon, but all good points by Dr. Farakbash. Thank you for your commentary. So are you going to do that in your own environment one day, Dr. Rao, after you've seen that? And how is it in Florida?
In Florida, it kind of depends. At the University of South Florida, we still do a lot of open deformity corrections. We'll do some MIS, again, if it's more indicated for that population. But kind of the surrounding private practice area, they do a lot more, 2, 3, 4 level, minimally invasive, not as much deformity correction. A lot of that comes to our institution. But I think this patient was able to mobilize pretty much right after surgery, other than his quad weakness. But he could probably have easily gone home the next couple of days. So I think in my hands or in my practice, probably do limited fusions down to lumbosacral, maybe 4 or 5 level fusion max, but kind of depends on the surgery or on the patient itself. But I think if to correct this kind of deformity, personally, I would probably do an open deformity correction on him.
Great. Okay, thank you. So next, thank you. Nice presentation. So next we have D3, Dr. Don David Davis III, and he's put together a case that he saw in clinic. So these are all recent cases. Thank you, Gautam.
All right, good morning.
So he saw this patient in clinic, and fire away.
Yes, sir. This is a patient that we saw that presented a couple of years ago, and we've been following her course over that period of time. I have no relevant disclosures for this discussion. So this patient is a 50-year-old female who presents status post multiple surgeries for failure of hardware with thoracic myelopathy upon her initial presentation to us. She had a remote history of a 4 to 6 ACDF that had healed, and she had achieved good fusion with some proximal and distal junctional kyphosis. 2 years prior to her presentation to us, she had a stage T10 to pelvis with failure at T10 to 11, 2 weeks postoperatively that was revised from T4 to pelvis. And then 1 year later, underwent a cervical revision for, again, proximal junctional kyphosis at the T3-4 level up to C2. Upon our presentation today, these were her x-rays. She was in a brace, and she was aware of the failure of hardware and was referred for a second opinion of management. She did have some weakness that was largely due to pain, according to the note, but also did have some finger abductor weakness. And then we can see that she has had failure of hardware. She had that PARS screw at C2, and then all the lateral mass screws have unfortunately failed as well in the cervical spine. You can just again see that despite the revision up to C2, she still had compression of the thoracic cord at T3 to 4. And you can see on her physical exam, I apologize that the video blocks that, but she had a positive Babinski and clonus, as well as lower extremity hyperreflexia without a Hoffman's. Again, we can see on our advanced imaging here, more detailed view of this failure of her cervical construct. She does have fusion at 4 to 6, but you can see the degenerative disease and a relatively flat profile of her neck at 3, 4, and 6, 7.
So this patient came to us, if you don't mind, this is a nice start. Go back to the initial film. So this patient came to us from an outside hospital. And if you just look at this construct, do you remember how many surgeries she had? So all these surgeries were done elsewhere, like 4 or 5 surgeries?
Yes, sir. So 2. the ACDF was remote. We don't have an exact date of that procedure, but then the T10 to pelvis was revised within 2 weeks of the initial. So she was in her acute rehab phase. Unclear if it was an actual fall or just an acute onset of pain, but she had failure and was revived almost immediately. I would say that, there's a lot of discussion that at what point in the presentation is appropriate, whether at the end or now, but there's a lot of discussion about the value of a kyphoplasty and cementing the screws at the level and one above. Would that have prevented her progression to T4? But it just seems like a really aggressive progression up the spine.
So Alan, this is very hard to unpack all this, but this kind of shows one of the criticisms in our profession, that is once we start doing these quote big fusions, we can engender a kind of a torrent of subsequent procedures. And this patient, without having all the old images available, she literally within about a year or two, I think, had 4 or 5 additional surgeries leading up to C2 fusion that then pulled out. And she came to me because the outside surgeon had said he needs to fuse it to the occiput because C2 pulled out, and she didn't want to accept that. She's actually she smokes very heavily, but she actually has a real job, and she just did not want to be a stick woman, a occiput to pelvis fusion patient. So that was my challenge why she came with. But just staying away from the C2 question right now, is there anything that strikes you as a problem here? Was there anything with the limited data that you have as you look at this gestalt now of fusions and repair things that strikes you as maybe preventable, short of not operating on her?
No. Overall, I always try to think about why somebody failed. And either you could have a major alignment problem that led to a very rapid failure. There could be a surgical technical problem, such as maybe his T10 screw was up in the disc base. Or they aggressively bogeyed up above the UIV. Overall, the alignment looks reasonable, I will say, meaning I don't think there's anything egregious. And we all have failures, but I agree that, Jens, I think we need to think very carefully when someone fails rapidly at the thoracolumbar junction, then fails rapidly up near the cervical thoracic junction, then fails above. I'll tell you a couple of the failures I've had that were repeated failures. I cultured them, even though they didn't appear affected, and they grew P. acnes or staph epi. So that's something we should always think about, especially in a smoker. And we'll talk about strategies in a moment, but I don't blame her for not wanting an occiput fusion, and I would have also sought a second opinion.
For me, the nicotine question is a really big one because we obviously focus on bone healing, but there are clear indirect problems. In our UW time, I think I was a remote co-author on that, we could identify cartilage degradation through the incorporation of nicotine byproducts in the so-called C, the connecting protein of collagen. And so basically the carrying capacity in our animal model of collagen was much reduced, and the water binding capacity was a fraction. So there's a pernicious long-term storage effect. This is not something that remedies itself with quick smoking cessation. This is in there for years, like chemicals in the polar ice, I always say. So this is one thing. And the second thing is vascular disease. These people have really bad, she has some atherosclerosis, as you can see, but I think that their blood perfusion of the vertebra is much reduced. So I think there's a far greater collagen and collagen viability problem in terms of frailty of collagen and nicotine people. Any thoughts on the indirect effects of long-term nicotine use? And this woman is as intelligent as she is an avowed heavy smoker.
Yeah, there's no doubt. I'll just mention briefly that smoking affects all sorts of healing and outcomes, unfortunately. Smoking's even been associated with low back pain and disc degeneration long term. It's terrible for you. The real question is, do we tell smokers or previous smokers we're not going to fix them? Or do we just counsel them to say, listen, you're definitely higher risk, but I'm willing to embark on this journey with you? And I think it's different in different markets. I'll tell you locally, maybe I'll be persecuted for this, but I operate on smokers. I generally try to get them to quit, but I will do spinal fusions in smokers.
Now, we want to briefly jump to the C2 issue now, but I want you to stay on that AP, please.
Oh, sorry.
Dr. Daniels, I want you to remember that AP with those satellite rods, because this will, kind of giving it away, but this will play a role. So quick now, C2, let's go into C2. What happened there? So she wanted to not be fused to the occiput?
Yes. So the plan for her, she did not have the C2 imaging there, as well as the thoracic myelopathy. So the plan for her was to do an analysis of the vertebral arteries, and the plan was for pedicle screw fixation wherever possible in the cervical spine, including C2, as well as sublaminar wires to give adjunct construct stability. So you can see here through our sagittal, coronial, and axial views that we were able to get pedicle screw fixation in 2, 3, and 4, and then again, as well as 7 was virgin. So we were able to get pedicle screws there as well.
And we did if I may interrupt, we did an ACDF at 3-4,
Yeah.
anterior column distraction, disengagement, uninstrumented, just a structural allograft, and used that to tilt her head back to get a better cervical lordosis because she was fused into kyphosis.
Yes, sir. Stage 1 was to correct her flat neck at 3-4 and at 6-7, and then we revised the construct from 2 to 2 down to the thoracic spine, decompressed at the myelopathy, and we're able to do intradiscal osteotomies, as we can see here, to restore the alignment in the thoracic spine. Let's see.
So we did an upper thoracic intradiscal osteotomy at T2-3. I think Dr. Oskuyan helped with that also. And we're very pleased. We did that to kind of literally pull the head back, and we tied in our cervical thoracic rod system into the previous rod system. And again, giving it away, but we took the satellite rods out, I think, to have room there. But so we're very pleased with the salvage, and she did very well from this. The C2 screws, we basically put 2 pedicle screws all the way to the anterior cortex. And yes, we used under mini open technique C3, C4 pedicle screws to have ultimate upper cervical fixation, and they went without problems. And we pre-operatively prepared with a CT angiogram to make sure we had clear understanding of dominance. Is intraoperative CT scan, not navigation though, and sublaminar cable. So anterior posterior revision. And any thoughts, any comments on the subaxial pedicle screws that we used?
Did you use navigation for those?
No, I dare say that the Yenzobot and Yenzopass, which is the version of the compass, is better than navigation in the subaxial spine. My error margin is 1 millimeters, and we do. I want to acknowledge the danger of subaxial screws, but we do a small laminotomy. We put a probe on it. We literally drill right next to the probe. I learned that from Abumi, and I've been very happy with that. But it's not a routine fixation. I told the patient before, this is an extraordinary situation, and we're going very carefully here. Should we review navigation, or would that be your quote standard of care now?
No, I don't use navigation for almost anything. I will say the last time I used it about once a year, was a case almost identical to this where I did cervical pedicle screws, and I decided I also used essentially your technique of laminotomies, but I said I'll use navigation just as a supplement to get a slightly better idea about where I am in terms of sometimes, for me with cervical pedicle screws, not only the medial lateral, which is the dangerous aspect of it, is important, but actually getting just a really nice anatomic trajectory down the pedicle to get a big, nice long screw is important. And so I decided to use navigation almost as a tool just to help supplement. But I agree that because if your navigation is 1 or 2 millimeters off, it's probably much more dangerous than direct visualization of the medial aspect of the pedicle. So this is a great solution.
I do like intraoperative CT scans, and that was very helpful for us. I mean, we did have a high degree of reassurance beyond C-arm imaging. So we felt pretty good about ourselves. She's done well from this. She was very grateful. I think she stayed away from nicotine, although I have a pretty long proboscis, a long schnoz, and I did pick up a sense of what smelled like nicotine in the clinic. But go ahead, go forward. So she looked good. She was happy. She returned to a normal life. Yeah, these are some intraoperative images.
Yes, sir. So we have our final images here, and this is actually 2 years post-op. She has shown up in our clinic, and unfortunately, the keen eye will detect the rod breakage at the thoracolumbar spine. This occurred a few months ago. For now, she's not having any neurological deficit and doing okay. Given her history, it was recommended to continue attempted non-operative management for the time being, which I think is reasonable. Particularly with her history of failure in multiple surgeries.
So the point to bring home here is several learning points here for me, but one is this rapid out-of-control propagation of more and more adjacent segment collapse in the presence of a technically well-performed fusion. This is not casting shade on a colleague. This is a very good surgeon. Everything was done by the book, but I mean, this patient just went, literally her spine did not like a fusion, and wherever a fusion was done, technically well performed, I think without any malalignment issues or so, no infection, it started breaking apart up to reaching the coast at C2. And we always felt, we got CTs, I think I got a bone scan before, I didn't see any non-union. So talk to us about long constructs and rod failure. And again, in the area below the old rods, right where I put an end-to-end connector on her, she obviously now comes with a visible snap that she noticed and new pain. What should we do? Why does this happen? Some fully associated thoughts from your end would be appreciated.
This, we've written a couple papers on this, and this is an area of huge debate that we've had. There was a group of surgeons who said if someone truly has a solid fusion, you cannot break your rods. And the other group of surgeons says even if you have what appears to be a solid fusion on CT scan, bone scan, intraoperatively, you can still break your rods with so much force over time, and likely more common in smokers and patients with comorbidities like her. What I would say is I'd be a little nervous about leaving her rods because we've seen a few patients that look good for a while and then start losing their alignment correction, whether it's through compression fracture or distraction through a non-united disc. And the surgery, hypothetically, to correct this may be pretty easy. More rods, BMP, more decortication, or maybe even a minimally invasive lateral if you think that disc is open. So I might try to push her to do this because I'd be a little nervous that if you watch it, she may come in and something relatively catastrophic may happen. And the fix is not terribly invasive compared to what she's been through.
Yeah, so that's a very valuable point. And please address, I know your papers are landmark papers. So first of all, I took these satellite or adjunct rods out to do the end-to-end connection. Was that a mistake? Should I have kind of tried to do an even bigger surgery and kind of bypass this vulnerable zone, which is right above her interbody fusions in the lumbar spine, retrospectogram?
Well, maybe, but you got to have room for bone graft. You have to have room for soft tissue healing. This is a relatively thin woman. But I think her body shape is changing a little bit. Her thoracic kyphosis leaning a little bit further forward. So she is losing a little bit of correction. So in retrospect, sure, I think keeping 4 rods essentially all the way down the spine may be more optimal, but there's nothing free in spine. And you got to have room for bone graft, and you have to have room to close the wound over it.
So let me go back to Dr. Martin, Dr. Covey. Do you have a protocol when you have a patient with a longer rod who comes in with a broken rod? And what do you tell patients in terms of their risk of a hardware failure over time? Dr. Covey, do you want to take that?
I would, yeah, I typically just continue to follow the patient, for once a year. That's probably the main thing because these patients, you never know when something happens. But in a patient who's minimally symptomatic, and I think it'd be reasonable to say, okay, let's just have her follow up in 6 months or a year with this rod fracture that you see now. I'd be hard pressed to take her back, just especially with her long history. I think the risk of catastrophic things that Dr. Alpert we just alluded to, is probably a lot less than in the cervical spine or so, or in the presence of a lot of stenosis.
Dr. Martin, I told the patient, I try to, first of all, when I see or hear of a hardware failure, I tell patients to answer the first question, what's my second question? They have a 30% risk of hardware failure over time, and over time is ill-defined. Maybe that's an underestimate, but that's what I tell them at this point in time, until Dr. Daniels gives us a new paper. The question that I have beyond that is the metal. So is there a better metal? Is cobalt chrome better than anything else? Should we have bigger rods, 6.25? Are 5.5 rods maybe better because they're more elastic? So tell us about materials and metal design outside of multiple rods.
Well, generally the studies so far have been on 5.5 and 6.0 titanium alloy and cobalt. and all of them can break. We've seen them all break, meaning that a 6.0 cobalt is not some guarantee that they won't break. And I think all of us will see over the next 5 years more and more people talking about alternative sources for mirrors, different kinds of metal. But even that, I believe anyway, will break over time in patients with pseudoarthroses. So I think material science is interesting and important. And Bob and I have spent a long time talking about this over the years, that in this case, with what you had available, generally 6.0 Ti is generally what I go to, often with outrigger rods. If the patient's severely osteoporotic or I'm getting near the junction cervicothoracic, I may go 5.5 Ti for slightly less stress. But again, even 6.0 cobalt rods could potentially break in this individual over time. It's a little surprising with the amount of what appears to be a fusion mass, though. And so, yet again, I know you said she's not infected, but I just want to continue to say that I always culture these people, and we seem to find a lot of C. acnes, and we hold them 14 days. And the question is whether it's a contaminant from the lab or actually contributing to this. I don't think we'll ever know, but I swear in almost every broken instrumentation case I've had over the last 2 years, we've had C. acnes grow, and it's often between the 10 and 14-day mark.
We just actually recently had a patient, we'll probably show them coming a month there with P. acnes infection. We do look for it. I totally concur. So we put her into, what do we do for her right now?
She's in a brace right now.
We put her into a Jewett brace. She had clear surgery fatigue. She did not want more surgery. She was worried that I'd open up most of her spine, which is probably true. And we put her into a bone stimulator. Actually, we got approval for a bone stimulator. So that's what we're doing right now. And she's feeling more comfortable with it. She's reactivating. But she's on a 6-month, I think, follow-up protocol, and she has our phone numbers and backline numbers, so she'll let us know, and she's aerobically rehabbing. And yes, she had the nicotine cessation discussions. I think that's reckless as bone stimulation.
No, I'm a big fan of bone stimulators. In fact, we have a paper in JBJS about bone stimulation. It has a grade B recommendation in spinal fusion. I get criticized locally sometimes for using as much as I do, and I tell people there's better evidence for bone stimulation and spine fusion than almost everything else I'm doing. So as long as the insurance company is willing to pay, I like bone stems. Now, will it make a difference in this patient? Maybe not, but it helps her be an active participant and trying to get her through this. She can feel like she's tried everything prior to embarking upon another major operation.
Yeah. Remarkably, this patient and her husband are both biomechanically savvy people. They actually work in the metallurgic industry, so they've had a lot of great questions. Bob, any criticisms, any thoughts from your end about what we've encountered here and what I've done?
No, I think, I think your operation was well indicated and well performed. I liked the ACDFs as part of it, both from the standpoint of deformity correction as well as bone fusion. I would not have gone down to, I would not have revised her all the way down as you did not, but just stopped somewhere in thoracic spine. I would really emphasize tobacco cessation with her. That is something for me is a red line. I acknowledge, Alan, that there are patients that you just can't get to do that, but I just frankly decline to operate on those patients if it requires a fusion. And I like E-stim, but I'm not sure that E-stim, a year out, maybe, but probably is a limited effect. But I think. And I guess the last thing I'd say is it did look like the first thoracolumbar procedure was well done in terms of the alignment, and they got solid fusion. So that's accomplishing a lot. I suspect that they did not use any sort of prophylaxis for PJF, and we haven't really talked about that, but I think that's an important part of our armamentarium these days. I'm not a big advocate of cement, even though back in the day I did used to do that, but I found that led to rapid degenerative disc disease at the adjacent segment in many of my patients, and I've gone away from that. And now I think that the key element is augmenting the posterior column, and there are various ways of doing that with soft tethers and non-fusion techniques, and I think those should be a routine part of these procedures.
And Dr. Daniels, so just to pick up on something you said before, I was kind of halting my breath a little bit because you used the standard of care phrasing. Dr. Panagiotis Korovesis, thank you, Dr. Korovesis, for joining us. Said dual rods in the lumbar spine common now. Is that kind of, you said the SOC word, is that the standard of care?
Did I say that? I don't use that too much. I hope I did. I think I try to be careful about that because I don't think there is one standard in spine. So if I said it, I'd like to walk back on it. But let's just say that using supplemental rods is common and has been shown to be potentially beneficial to at least delay and potentially prevent instrumentation failure. And so I guess my own personal standard of care in my practice is I use a lot of supplemental rods.
So, and Dr. Ken Yanamura asked a very insightful question. Should we put a patient like this who does not have osteoporosis? She had all the DEXA scans done. I forgot the numbers, but there was not any osteopenia, even that I remember. She had very sclerotic bone, in fact. Should we put a patient like this on Forteo due to the demonstrated teriparatide, that is, through the demonstrated osteogenic potential of that medication?
Yeah, I think we should consider. I think the drugs, both Forteo and then Tymlos and also Evenity, also all have great potential to help us over time, probably achieve fusion and optimize outcomes. And yet again, the issue is that they're expensive, relatively hard to access. Injection therapies the patient are not always eager to do. And I've recently tried to start in my own practice Forteo and Tymlos distribution. It's actually not that easy to do. You have to have a fridge. The medications have to be, you have to have a nurse to help monitor the inventory and all that. And God forbid the fridge lose electricity, you lose a whole fridge full of meds, you're way behind on cost.
So I must say, this is a very insightful statement. Thank you, Ken. Again, in this era of fighting for every single study that we're trying to do, I think the stimulator cost us 3-4 letters. I have not done that for this kind of a patient clientele, although it might make sense. I'm pretty sure that the rejection letters will be there and written because it's, quote, not medical evidence, but physiologically it seems to make total sense. So again, kudos to you, and maybe I'm just in a healing impaired patient like this gonna try to fight the administrative battles with more fervor. Last case, we have about 10 minutes, so we gotta power through this case. Dr. Neil Patel is a fast speaker. Dr. Neil Patel is from Penn State, joining us from the Eastern Seaboard as well. Neil, fire away with this case of mine, a complication of mine.
All right, so we have, So we have a 65-year-old lady who presented with low back pain, progressive subjective weakness, the lower extremities. She had some frequent episodes of bowel bladder incontinence and some reduction in normal arterial range. In terms of her diseases, DISH and rheumatoid arthritis, most significant among others. She had remote history about 17 years ago of L4-5 decompression and fusion. And subsequently, 4 years later, talking about infection, she did end up getting discitis adjacent level and underwent 2-stage fusion, L3-5 initially, and then removal of antibiotic beads and reclosure with L2 to S1 fusion, which you can see there. When she presented to us more recently, she had just hip flexor weakness, knee extensor weakness, and EHL weakness. Otherwise, nothing pertinent on her labs. So this is her construct, and this is the MRI she presented with. And I want to kind of focus on that adjacent level, L1-2, that's becoming a little symptomatic for her.
So Alan, I want you to assume that I did all these earlier surgeries. I did them, I think, over 20 years or something like that.
Right.
She does have connective tissue disease. She does use opiates at an interim. She's a medical practitioner. She has DISH in her thoracic spine now, which has evolved over time. And she does have literally an impressive number of things. So I was trying to ride her out in terms of not doing more surgery. We are careful about not dissecting off the rostral PLC and facet capsules and things like that, so they're all preserved as good as possible, yet this patient just destroyed her L1-2 joint over time. Is that a foregone conclusion? Would a less invasive technique with far lateral surgery and percutaneous screws have given her more time? Any thoughts on these kind of current hot button topics?
Oh, yeah, Ehlers-Danlos in particular. I've operated a couple Ehlers-Danlos patients years ago, and then suddenly they had chat room. Apparently, they still have chat rooms, whatever that is now. And I started getting a whole slew of Ehlers-Danlos patients. And as soon as you see them on your schedule, you go, oh my gosh, because they just tend to have problems and be, let's just say, complex patients in a lot of ways. And so I think all of this is beautifully performed, and this may have just been a foregone conclusion. I guess one thing I look at in terms of technical performance, notice the screw in L2 is aiming up. I tend to try now to really have an anatomic trajectory of that screw. Now, again, that is not a technical problem. I guarantee those screws are perfectly performed, but I think there's a hypothetical that if you have a very anatomically trajectory screw, as long as it stays out of the joint at the top, there is some possibility that can help prevent some junctional problems. At least if you get some collapses, it's less likely to be in the disc. But so I try to get my fellows to always place anatomic screws at the cranial level of any fusion. But overall, these are just tough cases.
Yeah, I will admit that the right L2 screw is not perfect, but she actually had no neurology from this. And I want to draw your attention to T910 that Neil has very nicely elucidated. So as we're now thinking that we have to, this is after years of non-surgical care, and she did not want surgery. She had some pulmonary problems after the L2 extension. She now has a pseudo fracture, this Anderson kind of a lesion that our fellow panelist Tarush Rustagi nicely published on years ago. So at T910, she has this kind of a non-healed dish process. Cervical spine is pretty good. You see that down there, beautiful imagery there, Neil. So if we then decide to go higher, should we cross the T910 barrier? Is that something that plays a role?
Yeah, I think it does. I think you should at least strongly consider it. I mean, her spine is spatially fused, except for in that segment. So hypothetically, barring any major fracture above it, I think you're better served to extend above it.
So we have 5 minutes. So Neil, take us forwards.
All right, so we decided to address those two issues, and we ended up doing L12 intradiscal osteotomy. So you can see level up there, fluoro shots of us placing a cage. And then the fluoro shots on the bottom are the construct themselves. And then I put an adjacent myelogram versus post-op images to show you the intradiscal osteotomy and the cage there for final kind of construct. Intraoperatively, during this surgery, we did have pseudomeningocele at L12 facet joint, and that kind of with subsequent CSF leak, which was closed primarily without any issues, very uneventfully.
So intradiscal osteotomy looked good. I can tell you that without sounding defensive, I hope. There was no big dural tear. There was a longitudinal fissure of the true dura mater in the area of the facet joint, and we basically did a repair. The arachnoid was actually intact, so whatever, 5 or 10 cc's of CSF leak. There was intact turgor throughout. There were no neurologic problems. This will play a role. We took the instrumentation higher and show us how our post-op films looked. Yeah. Okay, they look pretty good. Actually, I thought we had a very nice realignment, and we corrected this kind of a lateral listhesis coronal tilt with the unilateral cage. So we're very pleased with everything. And then Neil.
And then subsequently, she developed altered mental status, dysmetria, things like that, and ended up getting a CT scan post-op that showed cerebellar hemorrhage. One of the concerns with cerebellar hemorrhage sometimes is it could be a venous bleed as well. So we got an MRV to make sure that any of her venous sinuses weren't clogged, and they weren't. So everything was open in terms of torcula and the sagittal sinuses, etc. So she got further worked up, and you could see the ventricles, and they're kind of started to grow in size as the fourth ventricle kind of collapsed down to the cerebral hemorrhage. So the middle scan is where an EVD was placed, and that's all she required. And with the CSF channeling, she had reduction in ICPs, and she did really well after that. And so I kind of looked at the literature for intracranial hemorrhages after spine surgery, and most common place to have cranial hemorrhage is cerebellum, and this occurs in 56% of patients. After that, intraparenchymal hemorrhage in about 17% of patients, and the rest of the bleeds are actually subdural, subarachnoid, or epidural hematomas. And I we also have a case from Penn State similarly, but we had an intraparenchymal hemorrhage, and the literature on intraparenchymal hemorrhage is you could have bilateral versus unilateral, and we also kind of pursued that with CT angiogram to make sure that there wasn't any intracranial malformations, AVM, aneurysm, that ruptured during the case due to anesthesia with the blood pressure going up or down. And the other thing could be amyloid angiopathy with age, could also, with the labile blood pressures, could cause an infarct that could turn into a hemorrhagic conversion of ischemic infarct.
So it's really nice to work in a neurosurgical hospital. Sorry to speak over you. We have almost no time. Rod, so it's great to have a partner here. I called him right away. I'm very aggressive with mobilizing my patients. I put a subfascial drain in. I was very confident about my repair, Valsalva, sealant, no leakage whatsoever. I think the bulbs remained without CSF. Why did this happen? Is Ehlers-Danlos a role, or?
Go back. No, I mean, I think it's probably from the shift in I think older patients tend to get this, but I think it's from the CSF hypotension. It's pretty rare, but it happens.
Yeah, I've never seen this.
Yeah.
I mean, this is obviously pretty.
It happens during cranial surgery too.
It's pretty horrifying. So
Yeah.
she's done remarkably well. She has some occasional vertigo now. Do you have the final images?
Yes, sir. So I just have the angles, and she was within the lumbar lordosis pelvic incidus angles before and after, and similarly with SVA as well. We did improve the SVA significantly after surgery. These are final images, and the construct pre and post-op.
And final comments on the construct. So quad rods, working rods, as we call them, spanning rods, connectors. Any thoughts from a construct standpoint? And have you seen this kind of an intracranial or posterior fossa hemorrhage, Alan?
It's absolutely beautiful. And, I know Rod says it's from the CSF leak, but what Jens is implying is he's had a lot of CSF leaks in his life and people don't bleed. So it's just unusual why, out of the hundreds and hundreds of CSF leaks he's likely had and that we've all had, why does one lady bleed? And maybe it is Ehlers-Danlos as a contributing factor, who knows? But construct looks great. I guess the only question is, does she really need cross-links? Did they do anything?
I say emphatically yes, and let's have a debate in the future about that. I have three arguments just briefly. So mechanics, A, B, the dural protection for longer procedures, because again, especially in the cervical spine, that kind of a secondary invagination is a problem. And the third thing is, for any re-intervention, it's a godsend to have a landing place for the dural space dissections, like a guardian, the metal lamina. So, but we can have hours talk about this, because but I think the benefits outweigh the deficits. I take it you are not in favor.
Well, I use them just from the last point, metal lamina. I love revisions when you come down, and to put connectors where crosslinks is easy peasy. I'm not so sure about the biomechanics, and I've seen some rods break at those segments, but I look forward to our debate. I think it'll be great.
So I did not fuse her SI joints. She's 3 months out. She's hurting in her SI joints now as the day goes on. I hope this is muscular. Should I have fused her SI joints?
No.
Oh, okay, thank you. Another debate to come. I'm going to ask Dr. Hart. I know he gave a brief introduction, to step up to the podium. Thank you, Neil. Great discussion. To formally introduce you for your talk today, thank you for your commentaries. And Dr. Hart, who's sadly announced that he's going to retire in the near future, is going to introduce Dr. Daniels properly.
Yeah, well, the near future being Friday, so.
Really?
Yeah. So we'll talk, Alan. So, well, it is a great privilege to be able to introduce Alan. And as I said earlier, he and I go back many years and have a very close personal and professional friendship. Alan is, I'm just going to read this. I think I know most of it anyway, but I don't want to miss anything. So Alan is a board-certified spine surgeon specializing in adult spinal deformity and other complex spinal disorders. He serves as the chief of spine for the orthopedic department at Brown University, Rhode Island Hospital and Miriam Hospital. He's also the director of spine surgery research and associate professor at Brown University, soon to be a full professor. and co-director of the Brown Spine Surgery Fellowship. He is a high-volume spine surgeon performing over 450 surgeries per year. His practice focuses on patients who suffer from scoliosis, kyphosis, flat back, failed spine surgery, degenerative spinal disease, as well as spinal trauma and spinal tumors. Many of his patients have undergone one or more prior spinal surgeries, although he does perform primary surgery when indicated. Dr. Daniels completed his medical school at Oregon Health and Science University in Portland, and his orthopedic surgery residency training at Brown University, and then a further spine surgery fellowship under the guidance of Mark Palumbo, another friend now no longer with us, and Phil Lucas, before being recruited back to Rhode Island as their partner. And as I have discussed with a number of patients, really the only spine fellows that get hired in their home institution are the ones that stand out the most. So Alan meets that bar. His research focuses on spinal alignment, optimization of clinical outcomes following deformity surgery, and prevention of complications after spine surgery. Additionally, Dr. Daniels is an internationally renowned researcher and has published over 440 peer-reviewed articles. 500 has given 500 national or international posters or presentations, and has edited 4 orthopedic education textbooks. He's a member of the AAOS, the Lumbar Spine Research Society, and the Scoliosis Research Society. And I've got to ask, are you not a member of CSRS yet?
Not yet.
Not yet.
Right.
Still to come. So with that, I'm anxious to hear your thoughts on spinal alignment.
Right. Can you guys see my screen?
Yes.
Perfect. We worked out the kinks. Thank you so much, Bob, and thank you to Rod and Jens. I really appreciate the opportunity to be here. This is a whirlwind tour, so you'll see a lot of cases. And here's my conflicts disclosures. And so we'll be moving quick. I want to briefly talk about Bob. You know, he's been sitting here touting my accolades, but I'll tell you that Bob was my first mentor in spine, and he's really the inspiration for me to pursue complex spine surgery. But he also sponsored me, and Bob taught me a lot about mentorship, which is a close friendship you have with people that help to educate you. But sponsorship is also important, in that people can help promote you in societies. And he introduced me and got me to be a member of the ISSG, which has been academically and professionally great for me. He's a true friend. Him and Sue are just two of the best people that I know. Thoughtful, altruistic, hardworking people. He and I have co-authored 99 papers, so we've done a lot of work together. And he's truly a deep thinker and a revolutionary. And I'll just mention, for those of you that don't know, for example, you know, patients love to come in and ask whether they're going to be stiff after lumbar fusion. And Bob, I will say, really followed the scientific method. He came up with an outcome questionnaire, the Lumbar Stiffness Disability Index. He validated, he studied it, he promoted it, and helped us to understand lumbar stiffness in fusion patients and deformity patients. And I think has made a tremendous impact in my practice for how I can educate my patients with that. He's also, you know, biomechanics and inventor. This is the study we did on the novel odontoid plate. And he's really interested in education. And I know for all the people he's trained over the years, he's thoughtful about how he educates. He's written a lot about spine education. And he and I spent countless hours talking about mentorship, orthopedic specialization, and spine specialization. So I just really want to say thank you to Bob. So as we talk about lordosis and alignment, this is a huge topic. This is something you could easily have an all-day symposium on. And so we're going to breeze through a lot of it. But the key is this. Since PILL was established as a parameter, which is the pelvic incidence minus lumbar lordosis, which is really only in the last 10 years, pretty much, our understanding of spinal alignment has evolved very rapidly. People have been studying spinal deformity alignment extensively over the last decade. But I think we're starting to understand that sagittal alignment and lumbar degenerative disease may be equally as important. So as a very brief review, because most people here are probably educated spine surgeons, we have global outcome alignment parameters and regional parameters. The SVA we briefly mentioned today, is sagittal vertical axis, just looks at how far the torso is in front of the sacrum. Well, if somebody's compensating aggressively and leaning back with an elevated pelvic tilt, they may have a relatively normal SVA. So these global parameters such as TPA and GSA were developed. Importantly, one of the main points of the talk today is that just looking at thoracic kyphosis or lumbar lordosis may not be enough. We need to understand the regions. What's happening from L4 to S1? What's happening from L1 to S4? What's happening in the proximal thoracic, mid-thoracic, distal thoracic spine? And then, of course, the spinal pelvic parameters. If we look back at history, you know, when some of the gentlemen in the room there started, you know, they had scoliosis x-rays, you couldn't even see the femoral heads, you're approximating, trying to find the vertebra. If you want to do an osteotomy, you might cut your x-rays. And then Photoshop came and you said, okay, now we can start to not have to cut our x-rays into pieces. And today, fast forward, we have automated measurements with multiple companies now that can measure for you. There's 3D analysis, there's EOS 3D analysis from a standing radiograph, and AI and machine learning maybe has the potential to really improve, you know, not only prognostication, but maybe it's going to tell us where our UIV should be, how much lordosis to place. I want to start with a brief cautionary alignment tale. There's a lady done in 2006 before I started practice, 3 to 5 fusion. You're going to see on these slides, these are SurgiMap. I have no conflict with them. These are SurgiMap measurements, and you'll see in red is bad and green is good. So overall, you say, well, her PILL was 10 degrees, but maybe a little bit of lacking some lordosis down L4 to S1. But overall, as a fusion, I think any of us would be reasonably happy with. Well, shortly after she starts to fail her L5S1 disc, anyone who does a lot of degen surgery has had this happen. 3 to 5 fusion, 5-1 disc fails, starts to progress. So the surgeon says, well, I'm going to do a femoral ring A-lift and S1 screws. And you can see now the patient seems to have fractured her S1M plate, maybe a little over-aggressive with the A-lift. And now her pelvic incidence has increased to 100. And you start to recognize now the deformity surgeons and complex spine surgeons start to say, like, oh, this is a problem. Really high pelvic incidence is a challenge. Well, a very thoughtful spinal deformity surgeon did an L5 PSO in Connecticut and got her better, improved her alignment, but you can see that she's still pretty forward, got disc degeneration, was taken up to T7 with a TLIF. So then she comes up to see me, 62 years old, she's healthy, completely miserable. And this x-ray, I think, shows why EOS is also important if you have access to full body. Look, overall, I would say to the untrained eye, you might look and say, you know, that x-ray doesn't look horrific. It's not great, but she looks okay. But when you start to see her EOS, you start to understand how much she's bending her knees, how much she's bending her hips, how jutted posterior her pelvis is compared to her femoral heads, and she's also got a PJK. So what do? Do you just extend her up a bit? Do you try to get more lordosis somewhere? Do you get better rod contour, just try to pull the spine aggressively? You know, we couldn't even measure her pelvic incidence on x-ray, so we get a CT scan, and I measure her PI as 137, which is a problem. So in my hands, I believe that an S1 PSO, or really more like a VCR, would be the best. You really got to change that pelvic incidence. I don't think just adding more lordosis is ever going to get you up anywhere near 137. So this is her resection zone of her S1 VCR that we did. These are immediate post-ops. You can see a lot of green, meaning I'm high-fiving my fellow, excited about the alignment, pre and post. And then you see, importantly, this is the custom rod plan and the successful achievement of alignment correction of 56-degree PI correction. And so a really drastic measure following what was, you know, what looked like an uneventful L3 to 5 fusion. So here's our cautionary tale to say, was anything done wrong at the beginning? Was anything done wrong in the second step? Could this have been prevented so we didn't have to do this massive surgery? Okay, so what's the spectrum of lordosis and lumbar alignment? We have normal, degenerated, deformed. Everybody knows that these two patients you see up here have a deformity or extremely severe degeneration. But what is normal lordosis? Well, there's been a lot of studies on it, and Roussely and the French have really revolutionized spinal shape. Virginie Lafage, who I respect greatly, has written a number of papers as well. And the idea is this, quite simply. The more pelvic incidence you have, the more lordosis you have. And this is some normative data looking at large populations of normal patients saying, how much lordosis should you really have based on your pelvic incidence at each lumbar segment? Now, there's going to be human variability no matter what. But the key is this. With a relatively low pelvic incidence, the apex of your lordosis should be relatively caudal, down about the middle of L5. As you increase your pelvic incidence to be a higher PI, the apex of your lordosis should be more cranial, more like at L3. And to achieve that, that means you need more lordosis higher in the lumbar spine. Furthermore, it's very important to recognize that all the lordosis doesn't come just from the discs. I love the intradiscal osteotomy technique. In fact, I use a kind of a very similar technique using PLIF or TLIF to get lordosis correction. But the idea is, A, if you have subsidence into the end plate, you may have less lordosis than you hoped. And B, if you're trying to measure how much lordosis you need, you really need to understand the shape of the vertebral body, not just the disc. And generally, one thing that's been promoted is that 2/3 of lumbar lordosis should come from L4 to S1. Well, I think that's reasonable. However, this actually is my EOS. I got the first EOS ever done at our institution, and my lumbar lordosis is 56 degrees, and I have 48 degrees from L4 to S1, so I'm way above the 2/3 rule. So again, why is that? I don't know. But there's a large variability in asymptomatic individuals, and so we have to be very careful about prescribing what someone's alignment should be based on their degenerated or normal spine. However, there's a lot of studies that have helped to try to guide what we should do with alignment and degen conditions to try to optimize outcome. And this really started with spondylolisthesis. This was a paper from neurosurgery looking at the fact that high PI, pelvic incidence, may be a predisposing factor to adjacent level disease. Since been many studies in deformity that have also showed that that's the case. And one theory on that was potentially that the patient has a hyperlordotic compensation above and is stressing their facet joints. Also, don't forget we need to understand how patients stand. The loss of lordosis is not always because the discs are dead or there's a true deformity. It may be that they have stenosis, and so how are they compensating? To help understand that, we do need to think about the compensation. That's why I showed my case where the scoliosis films really just did not look that bad to me, but as you got a full picture of the femurs and the legs, you understand that she's compensating aggressively with elevated pelvic tilt and hyperextension of the proximal lordosis in patients who are not fused in the panlumbar spine. When further exploring the degenerative population, people started to look at the lordosis, how much was performed at 4-5 and 5-1 TLIF. Now, I'll tell you that TLIF is often not a lordosing operation unless you do an intradiscal osteotomy or really compress down or really careful about how you do it. And this study found that with every 1 degree increase in a PI-LL mismatch after L4-5 or 5-1 fusion, the odds of developing adjacent level disease increased by 1.3 or 1.4-fold if it was a postoperative mismatch. And patients with a PI-LL over 11 had even worse predicted outcome. And so at least there's some data that says we need to really keep an eye on lordosis. This was another study essentially saying the same thing, that a lower PI-LL mismatch was significantly associated with lower rates of AST. In terms of trying to restore sagittal alignment at each segment, even with a PSO, if you have to resort to that, there's good studies that are now showing more and more and more that there's improved outcomes long-term, not only from ODI, but also the previous studies showing adjacent level disease rates are lower if you can optimize and increase the amount of lordosis. And we'll get at some further studies showing that there is such a thing as too much lordosis, however. But this was a systematic review and meta-analysis showing multiple studies that all have either trends or significant values showing that the postoperative lumbar lordosis or the PI-LL mismatch, essentially the more optimized they are, the better the outcomes for adjacent segment disease were. So if you fuse people flat, they're going to fail. And finally, yet again, this study looked at now the amount of hyperlordosis. I talked about why this might be. If you fuse this patient flat at 4-5 and they hyperlordose at 3-4, they end up getting higher rates of adjacent segment disease that require fusion, likely because the facet hypertrophy, ligamentum flavum hypertrophy, increased loading on that segment. So now I want to run through some degenerative cases as we try to understand spinal alignment and try to understand the ways that many of us who study this are trying to optimize alignment. This is a woman, I actually saw her yesterday for 2-year follow-up, 67, active. She's a physician. She's borderline osteopenic, osteoporotic, not a smoker, luckily, because I know that Bob would look down on me for operating on her if she smoked. She's healthy. She's got just a grade 1 bordering grade 2 spondylolisthesis, isthmic. You can see on flexion extension, it's not autofused. It does move a little bit. When we measure her out, however, this is the interesting thing going back to the 2007 neurosurgery paper. She's hyperlordotic, likely above this 5-1 segment. But if you just measure PI-LL, it looks fine. And if you measure L4 to S1, it doesn't look too bad. because she's compensating with more lordosis than she really should have for a healthy spine. And my theory remains that you place more stress on the upper lumbar segments the more lordotic they are, especially in a low PI patient like her. So if you can restore lordosis, it will take us years to really prove this, but you will protect the segments above. This is Basil Debo, who was my fellow previously, and now my partner, who's obsessed with alignment. This was his drawing for this patient. He thought about all these patients throughout the year, and I would ask him how much lordosis to place in the cage. And instead of just throwing out a number, he would calculate all these things and look at data, and he inspired me to think deeply about these things. CT scans, I believe, are helpful, not necessary for patients with lumbar deformity, in my opinion, but I think helpful for understanding how big of the cage, what the bone looks like, how much you think it's going to move. Understanding the most important point of my entire talk today. If you don't address the stenosis, the patient will not be happy. Meaning if your alignment is great, but she has residual foraminal stenosis, your patients will never appreciate you. You must take care of the neurology first. And I would, not that you should ever choose between the two, but if you had to choose one or the other, taking care of the neurological compression is probably more important than the alignment, because if you don't fix the neurologic compression, the patients will hate you. So this woman got an anterior lumbar body fusion with a 15-degree cage to help. You can see she's now relaxed her L4-5 and L3-4 segments. I did place iliac screws, again, because of the amount of height restoration and the borderline osteoporosis. I did not treat her with Forteo before, and she's done quite well. Like I said, I just saw her for 2-year follow-up. Very happy. No adjacent segment disease at this point. What about someone who's already been fused flat, however? This was a woman, that had a T-lift with cortical bone screws, looks like a non-union at the bottom, now has developed spondylolisthesis above, potentially due to that flat segment and increased stress on the segment. So in my hands, I'd like to realign her. And to do that, you either need to do a PSO at L5 or an ALIF. And based on the work of Vince Arlay, I'm a huge fan of ALIF overpowering instrumentation and removing previous TLIF cage non-unions. I think the alternative would have been something along the lines of BMP in the posterior lateral gutters. My opinion is that an ALIF wins every day. And so we were able to get a couple extra degrees out of L5. And you can see the alignment measures here. A few more degrees out of L5S1, optimal alignment at L4-5. And, so far, patient has also done well. But again, you're going to see some more data coming up later, but it's going to take us 5 to 10 years to show we're really protecting people from adjacent segment disease by optimizing the lower lumbar alignment. So now we're getting a little closer to deformity as you start to see patients with multi-level severe degenerative disc disease and collapse. And notice where this measurement is. My research fellow measured this, and I said, well, it looks kind of like you're measuring L4-5 there. And so I showed this case at our Brown Deformity Conference, and we talked about a transitional anatomy. I polled 5 surgeons on how they define L5S1 when they measure pelvic incidence. I got 5 different answers. This was studied by Bob Eslack, ISSG, and our group. And we looked at how people measure spinal pelvic parameters when there's lumbosacral transitional vertebra. And you see that there's very low inter-related reliability and relatively low inter-rated reliability. So the key is I don't have an answer here of how to do it. Just recognize that if you measure your PI differently, you may plan your surgery differently. And then that may affect outcomes. Be consistent. So a patient like this who looks flat from L4 to S1 or L3 to S1, depending on how you measure it, but is hyperlordotic above, yet again, in my hands, gets 2-level ALIF because you can really dial in the lordosis correction from the front in a very elegant way. She's got a lot of green numbers over there. That means that she matches the normative data, at least, of what she should look like. And yet again, she also is at 2 years doing well. And so these were her intra-op pictures, it looks like. But I think it's on all of us in our generation to show what is optimal in terms of degenerative alignment, because so much of it came from the deformity literature that we'll get out here in just the next moment. So I think this is the kind of case that a lot of degenerative surgeons would tackle. This is not necessarily a complex deformity, a relatively small scoliosis with sagittal parameters that are reasonable. This, yet again, is Dr. Debo measuring every single level, saying how much lordosis do we need at each level. The key for this particular person is that you probably don't need all these measurements, but you should understand what you're going to do and think about your optimal alignment. And that's why I think that custom rods are nice, is that it helps to at least force the surgeon to think about their surgical plan. I do intraoperative assessment of alignment as well. You can see improved coronal alignment with basically not disturbing her harmonious sagittal alignment, which can happen. Here she is post-op. So does pelvic incidence adjusted segmental lordosis matter? Here's the real question. Does it really matter if we optimally align somebody and then fuse them long? And so this was a study looking at ISSG data to try to understand what happens if someone's overcorrected match or undercorrected in the lumbar spine. This was the normative data I showed earlier, and we looked at targets. And we showed that patients were most likely to be overcorrected at the thoracolumbar junctions if they had a lateral lumbar interbody fusion. That makes a lot of sense because if you're jamming a big cage laterally in the upper lumbar spine, it's pretty easy to push somebody over the edge into too much lordosis. People are most likely to be overcorrected L4 to S1 with an ALIF. Yet again, makes sense because ALIF is so powerful for realignment. And they're most likely to be undercorrected with a PLIF or TLIF at the bottom. Yet again, hard to realign the spine with those procedures. We also found there was a higher posterior inclination from T10 to L2 in overcorrected patients, meaning that water skiing patient we've all seen. Here's the meat of why it matters. There's higher rates of PJK and PJF in overcorrected patients. So if you overcorrect somebody and have them in that water skiing position, they're more likely to kyphose, especially thoracolumbar junction overcorrection. On the contrary, if someone's undercorrected and still leaning somewhat forward, they're more likely to have an implant failure. Virginia Lafarge talked a lot about this with me. You know, she talks all about the biomechanical stress on the construct, that when someone's leaning forward, essentially have this tension on the construct over and over and over again. Most commonly, of course, is rod breakage. These are 3 case examples. You see the patient who's undercorrected 4-1 has a rod fracture at 2 years on the left. In the middle, a patient who's matched who's done well at 2 years, and then a patient on the right who's overcorrected. You can see who suffered catastrophic PJF. Now, here's the key, though. There are better proms to people who are matched both thoracolumbar and lumbosacral junction, but at all remaining levels, whether they were under or overcorrected, there's equivalent proms, probably driven by fusion of painful discs and improvement in overall global parameters, and finally improvement in neurological syndromes. So what about the more complex patient? As we get on to patients who have already had deformity correction, reminds me of Jens's patient of the C2 to pelvis. What do you do with these people who come in who have a problem, who've already had long segment fusions? This was actually a fusion done by someone in our community, did a fusion, I believe it was eight years ago now, and she broke her rods, unfortunately. You see over time, she lost her correction, her lordosis, and he performed what I described earlier as a bit of a rod patching technique, just put bone and bone morphogenetic protein down and patched her up. Well, the problem with that is now she's got a fixed coronal sagittal deformity with a 44-degree PIL mismatch. The question is, how do you correct it? Where do you correct it? And how do you realign her? And my thought is this: she got an L5 PSO in my hands. If you look at all her alignment parameters here, you see that L4 to S1, is 32 degrees, which is pretty good. And so she's got a lot of red, but her L4 to S1 is well aligned and her thoracolumbar junction are well aligned. So based on that previous study, ideally she's good because she has good not only global alignment, but good 4-1 restoration of lordosis. So lordosis matters. This is what Bob was very excited about. I'm sorry to be at the last few minutes, but so do other parameters. It's been shown many times that self-image is one of the most important drivers of not only decision to undergo ASD surgery, but patient satisfaction with ASD surgery. And patients will often ask us, will they get taller? This is just like the question that Bob had of, will patients feel stiff? Well, will they get taller? And Zach Tadron came up with the question. We utilize ISSG data. And, I show a patient like this because you got to understand self-image. This lady who we corrected her coronal deformity, but sagittally has some PJK, absolutely hates her self-image, said she feels like a hunchback, and has been very dissatisfied with her surgery, even though I think, overall her parameters look good. So self-image can drive poor outcome. So here's the question: does height gain improve after ASD surgery? Well, we looked at 198 patients with 2-year follow-up, and we measured height in every single different segment. So all the way from the ankle to the hip to the lumbar spine, thoracic spine up, and then C2 to T1, as well as stellate turcica to C2. We looked at their coronal alignment and trunk height, as well as their sagittal alignment, lower extremity height. And the reason being, if you think about it, coronal deformity generally improves height by fixing scoliosis. Sagittal deformity improves height by improving the compensatory mechanisms of lower extremities. We found 3 out of 4 patients experienced height gain with a mean of 7.6 centimeters. Very importantly, height gain correlated with improvement in both SRS appearance and PROMIS scores. And finally, we came up with novel formulas to show that it really can be predicted. Most importantly, let me mention, though, it can only be predicted if the surgeon can accurately predict how much correction they'll get. That's a big assumption. So, by the way, that paper is coming out in JVJS, is on online printed now, and really appreciate the collaboration between the Seattle team and us. So this was a whirlwind. I wanted to try to cover as much as possible to say that we know lordosis is clinically important, but it's really not fully and completely understood at this point. You heard me say multiple times, we need to further study degenerative patients to show that 5 and 10-year data shows that optimizing and matching lumbar lordosis, ideally, I believe, to age and PI norms, will optimize and decrease the rate of adjacent segment disease. Of course, things like P. acnes infections, malpositioned screws, smoking, all influence outcomes. So you have to have really highly powered studies to understand this. I believe we should be playing lordosis on all fusions, at least thinking about it and monitoring it over time. And there are definitely risks to over and under correction. Thank you very much.
Outstanding, absolutely brilliant collection, great grasp of deformity. And again, I think underscores one of the most important things about fusion surgery, and that is any fusion surgery is a deformity surgery, even if it's a single level, regardless of the level. And I think John Kostick was the one who bore that out. Dr. Hart, any thoughts from your end as you're reviewing your former disciples' great accomplishments here?
Well, first of all, thank you for your kind words, Alan. And I don't think there's a lot to belabor here. I guess I'll use a couple of quips. One is it's all about the lordosis stupid. And we have come to see that more and more strongly over time. And, I remember my training, we didn't really even think about it 25 years ago. And now it's fundamental, and we're getting more and more information about segmental lordosis as you're sharing here. And then I would also say about cervical lordosis. So that's also fundamentally important and hasn't been recognized. And the second quip I'll use is a well-known, and I think came from Dr. Akbarnia, which is, we're all deformity surgeons. Anybody who does spine fusion is a deformity surgeon. You're either treating it or you're creating it.
Or both.
Yes.
So let me ask you a contentious question. So since we brought up the MIS thing earlier, is MIS surgery more or less able to restore lordosis? Because I'm going to go down to clinic now. I'll see 30 patients, and I'm pretty sure half of them have had surgery. And I can pretty much assure you that there's a strong preponderance of patients who've been undercorrected in what I see done. And certainly with MIS surgery, it seems to just be a matter of trying to stuff a cage into a disc space rather than actually spreading it back out again and lordosing it, using it as a fulcrum. So MIS and deformity correction in the general practice, where do you see that?
Oh, I think MIS TLIF is a kyphosing operation in many, many, many cases, and has great potential to be the next epidemic of flatback that we have to treat. But that being said, I think there are techniques with minimally invasive surgery. If you call L5S1 ALIF, MIS, some people do, that can be relatively minimally invasive. Or a lateral ACR has potential to achieve great lordosis, but there's a lot of risk of getting too much lordosis in the wrong place. So I think probably in the right hands, it is possible to achieve excellent correction with MIS, but let's just say I haven't seen it. It's rare. There's a few very skilled people around the country who are able to do it, but it is tough.
Yeah, we had Dr. Pimenta and Dr. Uribe and Dr. Osgoyen here together
Right.
during the fellows course. And again, what struck me was how diligent and attentive to detail all those three initial propagators are towards getting an anterior column release and all that, and how in the reality, it seems that most people just want to get their hardware in and get out and don't have this attention to detail, don't do the disc prep and the release. So that's my thoughts. All right, Rod, any thoughts from your end as to what you just heard? Is that going to change your practice? How's it going to influence what you see or do?
No, that was an excellent talk, and thanks so much for taking the time to share your wisdom with us.
We're at time, so Alan,
you.
great to have you here. Bob, may I ask you to make a pitch for your deformity course coming up?
Sure. I think, Alan, are you talking at it again this year?
I'm not sure. I got to check my calendar.
Yeah.
You should.
I certainly hope you are. So there's still
Yes,
time.
yes.
Yeah, there you go. Good. So
Better answer. Wrong answer.
yeah, good. So that's coming up, I think, in another week, or maybe it's a week, maybe two. It's the end of, what is it? Yeah, it's August 26th. Corey, thank you. So yes, please tune in. We've got a great faculty, and this will be my last year as chairing that course after, I guess, 8 years here at Swedish. I've been here 7, and I think this is the 8th course.
All right. Well, this will conclude. Thank you all for your participation around the world. And Alan, can't thank you enough. Learned a lot and appreciate your insights, and see you soon. Take care.
See you all in Seattle.
So fun. God, I can't believe I didn't know he was doing
And SRS, next one is beginning of September.